Are there rituals you feel you have to do because if you don't, you worry something bad is going to happen? Is it OCD? What's the difference between anxiety and OCD? Welcome to Session and Secrets.
Distressing, where it's really impacting your everyday function, either at work.
Become worried and anxious or I get stuck in my thoughts.
Then we wouldn't be motivated to engage in certain things. Like if you have a big test coming up, if you had zero anxiety, you might not be motivated to study.
When we talk about anxiety, we think about racing thoughts.
Maybe they're in the kitchen and they see a knife and they suddenly have an intrusive thought. What if I picked up this knife and stabbed my family?
And today we're in session with Dr. Jennifer Siegel. Welcome, Dr. Siegel.
Thank you so much for having me.
Can you tell me a little bit about yourself and what you do?
Yeah, so I'm a psychiatrist. I specialize in OCD-related disorders, as well as anxiety spectrum disorders. I have a background, though, in art prior to going to medical school at the University of Pennsylvania. And there I really work to try to incorporate art into medical education. And that passion for medical education has followed me out here to LA, where I often give lectures at places like IOCDF, OCD SoCal, organizations that specialize in OCD. And I also currently work part-time in private practice, as well as part-time at a partial hospitalization program, an intensive outpatient program for those with OCD.
Thank you for being with us, Dr. Siegel. And anxiety disorders, obsessive compulsive disorders affect millions of people here in the United States and throughout the world. And I have some statistics. According to the National Institute of Mental Health and the Centers for Disease Control and Prevention, the CDC, the prevalence of anxiety disorders in the United States is as follows. Lifetime prevalence is 31.6% of adults aged 18 and older have experienced an anxiety disorder at some point in their lives. And 19.1% of adults experience an anxiety disorder in the past year. When it comes to generalized anxiety disorders, 6.8% of adults have generalized anxiety disorder. How do you define generalized anxiety disorder?
Yeah, so generalized anxiety disorder, also known as GAD or GAD, has a specific set of criteria that we can find in the DSM. And so technically speaking, if we're going strictly by the books, generalized anxiety disorder is defined as having significant worry more days than not over at least a 6-month period. And that worry is pretty distressing, where it's really impacting your everyday function, either at work, your daily social life. And it also is associated with at least a few symptoms. So things like insomnia, difficulty concentrating, bodily sensations. And it is something that really has to not be due to anything else. So we make sure first it's not due to a medical condition, not due to substance use or excessive caffeine intake, things along those lines. And yeah, so that's kind of how we define generalized anxiety disorder.
What health disorders could be misdiagnosed or misdiagnosed with anxiety?
Yeah, I think that's a great question. So obsessive compulsive disorder, which I know we're going to get into a little bit, is something that is often misdiagnosed. There are specific subtypes of OCD, also called somatic OCD, which I know we'll talk about a little bit later. But essentially, those can be misdiagnosed as other forms of anxiety disorders like illness anxiety disorder, somatic symptom disorder, and then other things like panic disorder, social anxiety disorder, are all very interrelated, but they're all pretty distinct.
Okay. And anxiety often disguises itself.
Mm-hmm.
What are some subtle ways it can show up in people that they may not recognize?
Yeah, that's a great question. I think first I just also want to point out that a lot of us experience anxiety and stress every day, and it's not necessarily to the level of being diagnosed with a disorder. And in fact, sometimes having a little bit of anxiety is good for us, because if we didn't have any anxiety, then we wouldn't be motivated to engage in certain things. Like if you have a big test coming up, if you had zero anxiety, you might not be motivated to study. So we do like to say it's good every now and then to have a little bit of anxiety to give you that drive. But once it kind of tips over and becomes too much, then it becomes concerning. There's actually something called the Yerkes-Dodson law, which talks about this. So it's this sort of bell-shaped curve where if you have no anxiety, then you're not that productive. You have an optimal amount of anxiety, you're productive. And then if you have too much, you're also not productive on the other side. But yeah, to answer your question about how anxiety can show up in everyday lives, sometimes when it is more distressing, individuals might think to themselves, if they're working professionals and they're working really hard, they might feel like a lot of guilt about taking a break, like they haven't earned it yet. They might find it hard to set boundaries with other people or their boss, because they're worried about the consequences of that. And it can also manifest as like sleep disturbances, changes in appetite, and then a lot of physical symptoms as well.
Do you think that in our culture, in today's culture, do you think that just the fast pace that we're living in, do you think that has exacerbated anxiety?
Yeah, that's a great question. I think that there are certainly components of changes culturally and in our current climate, a lot of resources and people are being stretched thin, and I'm sure that's leading to burnout, and then that's associated with anxiety too. But I think also as a culture, we've become more accepting of anxiety in general, and so perhaps in the past, people who were anxious were less likely to go out and seek treatment for anxiety. And as we start to all come together and destigmatize mental health, I think more individuals are also coming forward, seeking out resources. And so it might appear as though there is an increase in anxiety when it's really people are more open to getting treatment.
Yes. And when we talk about anxiety, I mean, we think about racing thoughts, endless what ifs, and sometimes fears of or catastrophizing, right? Thinking the worst outcome is going to happen.
Yeah.
What what is the relationship between anxiety and OCD?
Yeah, that's a really good question. So anxiety, I like to think of as sort of like a spiral. So when someone's anxious, there's a lot of what if statements going through their mind. What if I get a bad grade on this test? What if I fail the class? What if I fail out of school? What if I never graduate? And all of these sort of what ifs, catastrophizing, like you mentioned, sort of in this downward spiral. And the spiral can get really large and it can sort of expand into all areas of our life where we start to worry, am I going to be able to make money one day? Am I going to be able to do this? Whereas OCD, rather than being like a spiral, it's more of a loop. So it's more of we have an intrusive thought about something specific, and then that thought makes us anxious. And then we do something temporarily to relieve that anxiety, but that anxiety is only sort of briefly relieved. And then we end up being anxious again, and then sort of repeating that loop of doing something to help with our anxiety. And then we just sort of get stuck in this loop. So those are kind of one ways to sort of help differentiate the two.
So the difference would be anxiety, you're going, like you said, we're going down. And then with a loop with OCD is like I become worried and anxious or I get stuck in my thoughts.
Yeah.
And then it follows with an action, right? That becomes a ritual over time.
Yeah.
And then we just keep
exactly
reassuring that circle,
that
loop.
Yeah. So maybe giving an example can help. So thinking, for example, maybe I just left my house and I have an intrusive thought, did I lock my door? And then I become anxious because if I didn't, someone could break into my home. So then that might make me do something like check the lock on my door. And then for those without OCD, that'll probably be enough. They know they lock the door and then they'll move on with their day. Whereas someone who has this specific subtype of OCD might then, even though they just lock the door, go back and check the lock 2, 3, 5, 10 more times until it really feels like they know for sure. And then they might even leave their house, get in their car, go where they're going, and then have that thought again and still not trust that instinct. So then they do another behavior. Maybe they drive home and see, like, is the door still locked? Maybe they take a picture of it so that when they're at work, they can prove to themselves, oh, I did lock the door. And so with all these examples, there's this temporary relief of like, I checked, and it relieves that anxiety briefly, but then there's always this, but what if? And then it kind of feeds that loop again.
Okay. In the United States, here are more statistics. About
Mhm.
1.2% of adults have OCD or had OCD in the past year, and 2.3% had it at some point in their lives. And this translates, it doesn't sound like a lot, but it translates to roughly 2.5 million adults.
Mhm.
That's a lot of people.
Yeah, yeah.
Yeah, and also children and teens, right? The statistic says at least 1 in 100 kids and teens are estimated to have OCD. And OCD, the onset is OCD most often begins in adolescence, but can start in childhood and or early adulthood. What are those signs in children and teens?
Yeah,
Um,
that's a great question. I think that for a lot of us, when we think about OCD, we think of individuals who are excessively washing their hands and are worried about contamination, or we think of individuals who are, very intent on making sure that they've been organized or things are symmetric. And that's because that's what's been portrayed most often, I think, in the media. But there are so many other subtypes of OCD that are less talked about, which really increases, the potential for these misdiagnoses. And I'm happy to talk about those subtypes as well.
yeah, what are the subtypes?
Yeah. So other less common talked about subtypes. So one big one is harm OCD. So this is when individuals have intrusive thoughts that are ego dystonic, meaning that they don't agree with these thoughts and they're actually very scary thoughts. Like maybe they're in the kitchen and they see a knife and they suddenly have an intrusive thought. What if I picked up this knife and stabbed my family? And that scares them. And they're like, oh, that's not me. I don't actually want to hurt anybody. But then the compulsion in that situation might be, okay, I'm going to stop using knives. I'm not going to cook anymore. Maybe I'm not even going to go in the kitchen because I'm scared I could impulsively do something. Other forms of harm OCD, maybe you are driving and you hit a speed bump, and then you have an intrusive thought like, did I hit someone? Even though it was just a speed bump. And then you go back and you check multiple times to see if anyone was injured. Um, Other forms of OCD, relationship OCD. So this presents as, maybe frequently wondering, do I love my partner? Do they love me? Which of course can be normal in certain situations, but it can become really excessive. And the compulsion there that I often see is reassurance seeking. So maybe asking your partner over and over and over again, do you still love me? Do you still love me? Replaying situations in your head over and over again, rereading text messages over and over again. And a lot of different ways that can show as well. Some other forms of OCD, pedophilia OCD is a common one, and there's a lot of shame about that one and stigma and fear in bringing that up. So what if I'm a pedophile and I don't even know? And then those individuals really don't align with those thoughts, and they might avoid like walking near schools or looking at movies or TV shows that have kids on them because they're scared of those thoughts. And another common one, which I know I mentioned earlier, is somatic OCD, which is can be thought of as either sensory motor or health-based OCD. So intrusive thoughts about what if there's something wrong in my body? What does this mean? And then excessive checking of bodily symptoms or Googling and reading Reddit posts over and over again to sort of get some certainty on something. And all of those can manifest as several different ways. But yeah, all very important. And then there's other subtypes like morality-based, religiosity-based, but I'll pause there because I know I said a lot.
Right. Or health-related, right? Fear of getting sick?
Yeah,
or
yeah.
illnesses?
Yeah, so health-related OCD, sometimes it's called somatic-based OCD, and sometimes it can overlap a little bit with contamination-based OCD, but oftentimes this might manifest as things like noticing your heart rate and then wondering, like, do I have an arrhythmia? Am I about to have a heart attack? And then maybe you are constantly like checking your Fitbit like several times a day to see what your heart rate is. Or maybe you feel like you have a pain in your side and you're worried you have appendicitis. You go to the emergency room, they tell you you don't. But then maybe for someone with this type of OCD, it doesn't end there. They might go like 10, 20 more times, go to different people for different opinions to really make sure that they don't have something like that.
Does it happen after, do you think does it happen after having a health related problem, or it just that worry and the thoughts that they just come without any context of having had any health related problems?
Yeah, great question. Both. So I certainly have individuals who just sort of have health-related anxiety, but they haven't personally experienced something themselves. They haven't had like a relative or someone close to them experience something, but maybe they, it kind of could come out of nowhere. Maybe they're scrolling on Instagram and they see a scary story of something happening to someone their age, and then it sort of feeds into these thoughts. But oftentimes I also see individuals who've had very real medical issues, and maybe they've had some traumatic events, or they have been in the hospital for some reason, and then that can sort of be the trigger. And then it becomes complicated because you could have both at the same time. Maybe you do have someone who has a autoimmune disease, which does come with checking. Like, for example, if someone has diabetes, they might need to check their blood sugar every so often to make sure that they're not in a dangerous way. But then it can get pretty interesting, because when is that in the realm of what's appropriate for a medical diagnosis versus what's OCD? And I can go into that too, if that's helpful.
Yes.
Yeah. So what I like to say is, if someone, in this example I use, maybe they have type 1 diabetes and it's important for them to check their blood sugar every so often. What I like to do is, what is your endocrinologist's recommendation about how often you should be checking your blood sugar? Maybe it is like, you should just do it before each of your meals 3 times a day, and then that's great. But then if you're telling me, okay, I'm actually measuring it like 20 times a day, then that would be more in the realm of OCD, because it's outside of the scope of what the medical recommendations are. And so in that case, we'd really sort of have to tease apart and think about it. This is beyond what's expected, even though there is some checking that is expected of you because you have this illness.
Yeah. When clients come to you, patients come to you, do they have an awareness that it might be OCD, or they just think that it's anxiety, or that they're feeling a certain way and that's why they're coming to you?
Yeah. Honestly, it's kind of mixed. I would say it's important to note that OCD is very much often misdiagnosed. And on average, the studies vary, but it's anywhere between like 10 to 15 years where individuals with OCD are misdiagnosed with something else, or they're just not diagnosed with anything at all. So I've certainly had individuals come to see me with other diagnoses, but then when I evaluate them, it's really actually OCD and not generalized anxiety or other things they might have been misdiagnosed with.
Okay. And what's happening in the brain when we're experiencing anxiety or OCD?
Yeah. So there's some overlap between the two. So in both, we have our amygdala, which is part of in our brain, and that's sort of our fear center. So when we see something scary or we're nervous about something, that gets activated. And then that sends signals to other parts of our brain, particularly in our prefrontal cortex or in our hypothalamus, which then can trigger a cascade of other hormones being released in our body. It tells our adrenal glands to release adrenaline or epinephrine, norepinephrine, and kind of put us in that fight or flight response, or sympathetic nervous system. We often call that the fight or flight response. And in OCD, it's sort of the same when you kind of had that heightened anxiety. I would say there's more sort of research in terms of like a tighter knit clear loop that's been evaluated in OCD. So there's something called the CSTC, which is the corticostriatal thalamocortex, which is just basically a fancy loop that we have in our brains that sort of, once it becomes activated, it sort of can keep us stuck in these types of loops that we see with OCD.
Okay. And are there are they the same hormones involved in us getting stuck in that loop?
Yeah, so good question. So in terms of like hormones involved, I'd say when I talked about our sympathetic nervous system being activated, and we have this release of epinephrine, norepinephrine, cortisol, we can see that in individuals who have more chronic anxiety, not just acutely. So it's, we all, if we were, about to be attacked by an animal or something on the street, we'd have this kind of sudden surge, which I just talked about. But for individuals that experience anxiety or OCD more chronically, all of these levels can be sort of increased more chronically, not just acutely. And then there can be physiologic consequences of that. At the same time, I think it's always important as medical doctors, if we're seeing someone in our practice and it's the first time they've been diagnosed with anxiety or OCD related symptoms, there is always a good medical workup to make sure that there's no other medical causes that could be contributing to the anxiety or OCD.
Okay. And how important is medication management with OCD, with the treatment of OCD?
Yeah. So, in terms of medication management, it can be really life changing for some individuals. It really depends on the severity of the OCD. So, if the OCD is more mild and that specific person is more hesitant to start medications, it might be totally fine to just start with the therapeutic treatment, which the gold standard is exposure and response prevention therapy. But once the OCD is becoming more moderate and severe, really the combination of medications and ERP, the exposure response prevention, are the gold standard.
And how do you decide which medication is appropriate?
Yeah. So that's a complicated question. So if someone is very new to treatment, the most common medication that we use for someone who hasn't been on meds before is selective serotonin reuptake inhibitors, or SSRIs. And it's important to make a distinction here too about these medications. They are sometimes in this drug class that we call antidepressants, but they are also anti-anxiety medications and anti-OCD medications. But what I think is sometimes missed is that the dosing between using these medications for anxiety and OCD can look a little different, and the length to efficacy is also different as well.
What do they do in the brain? I saw your post on Instagram,
Oh.
and I loved it about SSRIs
Yeah.
and exercise analogy. Can you tell me about that?
Yeah. So I think what a common thing that I see as a psychiatrist that kind of led me to make that post is that understandably, a lot of times people will start an SSRI and have a side effect to an SSRI, and it's really uncomfortable, and then they become nervous and anxious to try a different SSRI, which is totally valid. And in terms of why they may have had those side effects is because when we are taking a medication that increases our amount of serotonin in our system, it upregulates certain receptors that we're not used to having as upregulated, and then we are exposed to more serotonin throughout our body. And acutely, that increase in serotonin can lead to certain side effects. Most commonly are things like stomach upset. And that's actually because the majority of our receptors for serotonin are actually produced in our gut. And so our gut has to get used to the medication too. Other things like headaches, and then there's a whole other list of side effects. But the reason I bring that up is because while there are, a number of different medications that are SSRIs, they're not all the same. And it can be really hard to get buy-in to try another one if you've had a bad experience with one. But one of the things I like to tell my patients is think of it like an analogy. So for example, let's say you're going out for an exercise because it's good for you, and you find that you love running, and your friend finds that they love swimming or they love yoga, and it's just different. So for SSRIs, certain SSRIs are much more activating, like going for a run. Some SSRIs are much more calming, like going and doing yoga. And so it really kind of depends on the person. And if you were trying exercise for the first time, you wouldn't give up on all exercise just because you didn't like running. You might go and see if you'd like swimming or something else. So it's kind of the same idea.
Yes.
Yeah.
Thank you for that explanation.
Yeah.
And there's a lot of stigma with medication related to issues, mental health issues, to treat mental health issues. How do you help clients or patients understand the importance of medication management?
Yeah. So certainly there's a lot of stigma around medications. I think the first thing I always do is ask each person what their biggest concern is or what their fear is, because it tends to be different for different people. Sometimes I hear that they're scared they're going to be addicted to the medication. Sometimes I hear that they are nervous it's seen as a weakness and they shouldn't need medication. They should just be able to do it on their own. Sometimes I hear that there's a very specific side effect that they're worried about. And they're scared of weight gain or weight loss or whatever it might be. And sometimes I just don't have the education or knowledge about the SSRIs, and it can be very scary. So I think the most important thing is to figure out what it is for that person that they're nervous about, and then try to provide the psychoeducation around that so that they feel more empowered to have informed consent over the decision-making process.
Yeah. Okay. And Dr. Siegel, so something I've seen with my clients is like maybe their anxiety, but they would rather try cannabis. And they say like, oh, it helps me fall asleep. It helps me just calm down. What are your thoughts on that?
Yeah, it's a great question. I see this a lot too. And I see a lot of individuals actually sometimes, because of the stigma we just talked about, coming in trying cannabis or other sort of plant-based supplements or over-the-counter supplements, naturopathic medications prior to coming to see me. And honestly, I think that sometimes they can be really effective and that they can be great. But it's always really important to talk to your specific provider about that, because just because something is easily accessible over the counter or something that can be bought without a prescription doesn't always mean that it's safe or that it doesn't have any side effects or that it doesn't have drug interactions. So, but speaking specifically about cannabis, I think that, the education around the risks with cannabis is also an important discussion to have with individuals. There has been some research that's come out showing that individuals who tend to smoke more cannabis have long-term consequences of decreased working memory function, executive function. And so there can certainly be long-term consequences to that, as with psychiatric medications, but it's always important to talk about the risks and benefits of each. And then one important thing to note with cannabis specifically is that sometimes if someone is predisposed or at increased risk of developing something like psychosis, there is a much more increased risk to develop things like schizophrenia. So just having that on the back of our minds too.
Right. And yeah, like get you have to know your genetic makeup, right? Gets complicated. But so for someone who's afraid to start medication, what's like the realistic picture once they start?
Yeah. So I think the hardest part about starting medications for anxiety or OCD is that oftentimes the drugs we use can be really beneficial, but they tend to have side effects before you see the benefits. So like I mentioned earlier, usually if you start an SSRI for the first time, because we have serotonin receptors throughout our body, you might, like in our gut, like I mentioned, sometimes people experience things like nausea, diarrhea, headaches in the beginning. But those side effects do tend to go away after a week or two if you can stick it out. And you can also ask your prescriber about starting at half the starting dose, which is what I usually recommend, which usually minimizes a lot of those side effects. But it really takes, they say, at least 4 to 6 weeks at any given dose to get the full benefit of the medication. And in OCD, it really can sometimes take up to 12 weeks on any given medication. And I think that's really important because sometimes I'll see clients who have tried a bunch of medications and they've said that they've failed all these medications for OCD. But when I look back at their records, they really haven't been on the medications long enough. And so that's another place where that distinction is really important, because they maybe just needed more time or they just needed a higher dose, which we also recommend in OCD too.
Right. Yeah. Sometimes clients try it for 2 weeks and they're like, nope, it's not working, Luisa. And I'm like, okay, we'll talk to your psychiatrist. But this is helpful to know. Like,
yeah.
It will take.
Yeah. Yeah. And it's hard because I think the majority of medications we're used to taking over the counter work right away. Like if we have a headache, we take Tylenol and then it helps. And these types of medications don't work that way. They're really working at the level of receptors throughout our body, and it just takes more time for those receptors to upregulate and for our body to kind of get used to having increased neurotransmitters in our body.
Okay. Can you tell me briefly about exposure responsive prevention therapy?
Yeah, sure. Yeah. So ERP is the gold standard treatment for OCD. And so basically what you do is you figure out the specific subtype. It could be multiple, but start with somewhere where you're, understanding what their OCD is specifically about. So maybe it's about, going back to the example earlier with the checking of the locks. And what you do is you ask this person, what are some things that you might avoid doing because of your OCD that you wish you didn't have to avoid doing? So maybe some people have such severe OCD that they're nervous to even leave their house because it just takes so much of their time checking the locks before they leave. Or maybe they, feel like they have to check the locks at least 10 times. It's like ritualized before they can leave the house. So you end up building sort of what we call a fear hierarchy. And it's sort of these graded exposures based on these avoidances that I talked about. And so, for example, it might be, how scared would you feel if you could only check the lock on your door 5 times instead of 10, like you want to? And maybe that person says on a scale of 1 to 10, that would be a 5. And maybe I said, well, what if you could only check the door once before you left? Maybe for them, that's like an 8. And so you basically come up with a bunch of scenarios and you rank them from, 1 to 10. And these are your sort of exposure hierarchy lists is what we call them. So we try to work our way up the list. And the idea is you want individuals to feel anxious, which I know sounds really tough. And a lot of course,
Scary.
People don't want to feel anxious. But we intentionally, have them engage in these graded exposures up their list, tolerate that anxiety associated with that. And while they're doing that, prevent them from doing whatever the compulsion might be. So, for example, okay, you're going to check the lock on your door 1 time, and then you're going to leave your house, and you're not going to do the compulsion of going back home to check. And hopefully you're starting at a place that's sort of in the middle of the hierarchy. You don't want to start too easy or too intense. You kind of work their way up to like a 50% anxiety, have them sit with it. And over time, when you practice doing this multiple times, you find that anxiety associated with that specific thing goes down, and then you might be able to move up on the hierarchy. So yeah, that's kind of like the main way that we treat some of these things.
Okay, well, Thank you, Dr. Siegel, for bringing clarity and more understanding to OCD, anxiety, and the treatment of the disorders. And so where can people find you if they want to know more about you?
Yeah, sure. So I have a website. It's jennifersiegelpsychiatry.com. I also share some educational content on Instagram. It's ocd.psychiatrist.drjen. And yeah, if anyone has questions, they can feel free to reach out to me.
Anxiety and OCD can make the mind feel like a trap. But as we've heard today, with understanding and the right treatment, the mind can become a place of peace again. Thank you for joining us on Session in Secrets. Please make sure to like, subscribe, or leave a comment down below.